Hello everyone. So in this session, we are going to talk about lactogenesis, which is a very important topic asked in IBCLC exams. So in next few minutes, we would be talking about various stages of lactogenesis, what is delayed lactogenesis and why it occurs, what are the causes of failed lactogenesis and how it differs from delayed lactogenesis, and what is the role of lactational consultant in regard to lactogenesis. So let's begin the session and see what is lactogenesis. Lactogenesis is initiation of milk secretion. It's a general term used when the milk is started to secrete from the breast. It is regulated by three factors. The most important is hormonal factors, then is cellular factors, and then is autocrine factors. This is very important to keep in mind because the failure of lactogenesis can occur at any stage. Now, we have three stages of lactogenesis: stage 1, stage 2, and stage 3. Let's see in detail about each stage. Stage 1 of lactogenesis. It starts between 16 to 20 weeks of gestation. So, it is the preparation for breastfeeding starts much before the baby is even delivered. So between the 16 to 22 weeks of pregnancy, the lactogenesis first stage has already started. What happens is this time is that gradually the prolactin starts to increase. The hormone called prolactin is increasing. But why the mother is not able to secrete milk during that time is because progesterone inhibits its role. So because progesterone is also very high during pregnancy, so the role of progesterone is to inhibit prolactin. So it inhibits prolactin. So though the milk is started to get produced, it will not be secreted from breast. And then as soon as the baby is delivered, then because progesterone gradually reduces, and so the milk secretion would start, as now prolactin will be having an uninhibited action. So during pregnancy, colostrum in small amount might be visible, and that is because prolactin is working at a high level. In this colostrum, there is high IgA, but the volume is very low. Now what happens is lactogenesis stage 2. This is by far the most important stage, and this is one of the stages which is most affected. So if there is failed lactogenesis or if there is delayed milk production, all usually is because this stage is delayed. When this stage occurs between 30 to 72 hours of postpartum. And what happens is that there is decreased progesterone. As soon as the placenta is delivered, there is progesterone immediately goes for a toss and it becomes very low in a mother's body, and because of that there is uninhibited action of prolactin. The same diagram if you can see. So because you can see the prolactin was actually high, but it was not able to function because progesterone was suppressing its function. Now when the progesterone has become low, prolactin starts acting and now the milk starts coming in. So this is rapid, and there is rapid increase in the milk volume. This is between 30 to 72 hours after the delivery of the baby, and this lasts for a longer period. Then depending upon is it a cesarean section or is it a normal delivery, the action would the time would depend on that. And once this stage, though this is the smallest stage of lactogenesis, this stage is the most important stage because this is one of the stage which can be modified or can be affected through hormones. Now the next stage is a longest stage of lactogenesis, which is stage 3, and this comes at around 9 days of postpartum, 9 to 12 days depending upon either mother is primary or multi, or when was the milk started, when was the baby latched to breast, how was the latching, and many other factors. But this is the stage where the control of breast milk production is autocrine. Now autocrine means it's by the local hormones, and it's basically a local effect and not per se a body hormone effects. And it's more of a demand and supply mechanism. So the more baby drinks, the more breast gets empty, the more milk is produced. And this then stage continues till the mother is feeding. Now, this is very important because this picture shows that what are the hormones which are acting in lactogenesis. Most important hormone is prolactin, which stimulates the growth of the nipple and areola, and its increased production level drives milk production. Then is progesterone, which increases the growth of the lobes, lobule and alveoli, and it also enables lactation before birth. Its decline immediately after the birth, as we discussed, causes milk to secrete. Then there is estrogen. Again, it promotes the development and branching of the milk ducts. Then there is a milk ejection reflex, which is MER. And again, there is human placental lactogen also, which supports mammary gland development during pregnancy. So main hormones are prolactin, progesterone and estrogen. Also in some ways oxytocin, because it initiates the milk ejection reflex. So what we have to remember is mainly after delivery is prolactin and oxytocin, and before delivery it's mainly progesterone and estrogens interplay. Okay. Now, why failed lactogenesis occur? First of all, what is failed lactogenesis? Failed lactogenesis is no milk production by 72 hours. Even in primary or in multi, if till 72 hours the mother is not able to produce milk, that is called failed lactogenesis. This leads to supplementation of the formula and early cessation of breast milk. And this is one of the preventable things which can be done, and this is usually in lactogenesis 2 stage. So this can be prevented. Now let's see here, this is a very beautiful algorithm which explains what are the factors which are responsible for milk production. So if we know what are the factors and what are the inhibitory factors, we can work on it. So external stimuli like sound of the baby, if the mother is holding the baby in hands, crying, thinking of the baby, all these would increase milk production. And opposite of this is stress. So stress is one of the factors which can cause delayed lactogenesis. Then there is prolactin releasing factors which are positive effect, and then inhibiting factors have a contradictory effect. And then milk stasis in stage 3 of lactogenesis, milk stasis is one of the factors which can lead to delayed lactogenesis. Why? Because as I told you that it's a demand and supply. So if the breast is not emptied, the body gets a response that no more milk has to be produced. So again, the milk production reduces, and so is the milk secretion. What are the types of failure? So the commonest, as we discussed before, is also delayed lactogenesis 2. Though the lactogenesis 2 stage is a small stage, but this is a very important stage. Then there is also primary lactation failure. It is quite rare. It is when the breasts are not formed, if the mother has undergone surgery, if the mother is on chemotherapy or any suppressive drugs. And then there is again one more common entity, which is true versus perceived low supply. So mother feels that the milk supply is not enough, though the baby is gaining weight and is doing well. So 3 main causes of milk low supply here is preglandular, which is like needs the professional support, and glandular. So preglandular is not related to breast, so before the glands. And then there is glandular, which is related to breast anatomy and its pathophysiology. So if there is reduced glandular tissue, if there is previous breast procedures, and this is one of the causes of failed lactogenesis where there is no milk production at all. And then there is postgranular factor, which is like there is not enough secretion of milk because the breasts are not stimulated, or the baby is not latched properly, or the baby is not sucking frequently. So all these factors are postglandular factors. Now let's see in brief about what are the common causes, also some rare causes, both in maternal factors and infant factors, which can cause delayed lactogenesis or even absent lactogenesis, which is failed lactogenesis. So common causes in mother are hormonal or endocrine causes. Like if the mother is diabetes, this is one of the very common causes, and we have to remember as a lactational consultant that which stage diabetes affect is a lactogenesis stage 2. And it's because of a lot of factors. The main is there is reduced insulin. Then these mothers could be obese. So because of more of adipose tissue and fat also, there is delayed lactogenesis too. So as a lactational consultant, we have to be very cautious when we are dealing with a diabetic mother, and we have to prime her that this could be a delayed lactogenesis, but with good guidance and good support and frequent sucking of breast, this problem can be sorted out. So diabetes is one of the common scenarios which we face in our practice. Then is hypothyroidism, then hypopituitarism, Sheehan syndrome, which is like postpartum hemorrhage. Because of excessive postpartum hemorrhage in a mother, there could be failed lactogenesis. Then PCOS or PCOD, or if the mother was on hormonal contraceptive or any other medicine which suppresses hormones in general. Anatomical or breast factors like insufficient glandular tissue, also known as IGT, breast surgeries or injuries, there are breast implants. So these are usually the cases of failed lactogenesis. And even as a lactational consultant, there is not much help we can provide the mother except for reassurance. Or there is reduction, or there is reduction mammoplasty. Then pregnancy related factors could be this: the mother is preemie. So in preemie mothers, you have to work fast and you have to work frequently, which is you need to prime the mother before that the milk production would not start immediately. She has to stimulate the breast. We have to tell her to empty the breast frequently, use pump if possible, hand expression of milk can be done. Then is obesity, hypertension and preeclampsia. During labor and delivery, the problem could be because of stressful labor. Sometimes oxytocin has to be given during the time of labor to haste the delivery. That is one of the factors which can lead to delayed lactogenesis too. Then, as we discussed, postpartum hemorrhage. Then delayed initiation of breastfeeding. If there was a preterm, if the baby was taken to NICU and not started on feeding, and if the golden hour is missed, which is the first hour where if you initiate breast milk, the chances are that the lactogenesis occurs faster. So if that is there, then there could be low milk supply. And there are psychosocial factors also. If there is maternal stress, if mother is in pain, mother is not keeping well, mother was taken to ICU because of some reasons. If there is a history of cigarette smoking, or hormonal contraception had been taken before, during even after postpartum, if the mother was prescribed hormonal contraception because of some other reasons like PCOS or significant PCOD, or if there was no delayed skin to skin contact. So these are the factors which could lead to delayed lactogenesis or failed lactogenesis. In terms of maternal infant factors, it could be because birth stress, like child had a delayed cry, or child was immediately taken to nursery or NICU. The child required oxygen, not with mother, or it's a preterm baby, or the baby is hypotonic, and because of hypotonic baby there is poor latch, ineffective suck, or the child is sleepy, or there is a NICU admission which has called mother and infant separation. So what are the clinical signs? What we have to look for? So, and this we should start looking during the pregnancy. So even during the pregnancy, there is a role of lactational consultant that she should start examining. The lactational consultant should start, counseling the mother, check how is the breast and how the mother prepared to immediately breastfeed, or if any stress factors or any social factors which can be, or cultural factors which has to be talked about before the baby is even delivered. So what are the clinical signs? It could be no breast fullness by third or fourth day of delivery, and the infant is losing weight of more than 10% after 7th day of delivery, and the child is not passing enough amount of urine or stools. So how are we supposed to assess this kind of a scenario where there is delayed lactogenesis or failed lactogenesis? So we would examine, first of all, breast anatomy has to be examined. So check for symmetry, size, check if the glandular tissue is enough or not, how is the shape of the nipple, if it's everted or not, if it's flat, inverted, and if it's inverted, can it be after suction, can it be everted, or it's a temporary inversion, or it's a permanent inversion. If there is any nipple trauma because of the poor latch, if the mother feels very stressful, or if there is a lot of pain, signs of lactation is there or not, like if there's breast are engorged or not, if there is fullness of the breast, then take detailed hormonal history, like what were the breast changes during pregnancy. Ask for any medicines she's taking for thyroid, if she had any hypothyroidism or PCOS or diabetes, or how is the post delivery history, as in if she had more of bleeding, or is she on any medication. Also, most important here is to check for latch. So you can also do a latch score and also check one-on-one. So not as the mother, rather visually see it, if wherever possible, after the consent from mother, that how is she latching the baby, if the mouth is wide open, if there is no anatomical problem with the mouth of the baby, if the suck is good or not, and how is the milk transfer, if there is audible swallowing, if the breast is softened after the baby has breast for some amount of time, how much is the frequency of feeding, how often does she latch the baby to the breast, and how is the weight gain of the baby. So how do you manage? So management, again, in any scenario where we are dealing with a mother, it's always a multidisciplinary team approach. We never work as an individual. We always work as a team involving the pediatrician, the neonatologist, the gynecologist, and us as a lactation consultant. So what is our role here is to optimize the latch. That's the most important thing. So check for the babies has a wide mouth open, the latch is deep or not. There should be no pain while, how is the position? Is she comfortable during breastfeeding? And suggest her alternative positions if she's not comfortable in one position of breastfeeding. Now, how to improve transfer is check for audible swallowing. You can also advise her breast compression, massaging the breast, switching sides in between feeding, also pumping milk expression with hands, or that is hand milk expression can be done initially to increase the frequency of breast milk feeding. Ensure frequency. So we need to tell them that they have to frequently breastfeed the child, at least 2 to 3 hourly. So at least 8 to 12 feeds per day should be there, so that there is a rhythm which is maintained and the baby started to gain weight, and by 9th day when the lactogenesis comes to a autocrine control, there is not much of a problem. And long gaps initially should be avoided, and if necessary, wake up the baby after 3 to 4 hours and feed. Attach the baby to the breast, latch the baby to the breast and feed. Monitor outputs. What output we have to suggest them to monitor? Check for how many wet diapers are there in a day. Are the stools yellow or not? How many times the baby is passing stool? What is the color? Roughly how much is the amount? And obviously weight monitoring is the most objective thing which you can do. So the child should ideally start gaining weight by 7th to 10th day. On 10th day, most of the newborns are their birth weight. So after that, they start gaining weight. And again, there are medical management which has to be done if there is retained placenta, if there are any endocrine factors which are responsible, if thyroid medicine has to be increased, if diabetes has to be, if it's in check or not, and if required, galactogogues has to be prescribed. But that is again out of our role as a lactation consultant, and this should be discussed with the pediatrician and a gynecologist involved. How do you prevent it? It's a very important thing. So it is seen that almost 80% of cases of delayed lactogenesis 2 can be prevented just by good counseling, monitoring, frequent assessment of latch. And the major role here is of a lactational consultant. So what we have to do is impress upon the point of golden hour. The first golden hour, when if the breast milk is started or the child is latched as early as possible, there are more chances the mother would not land up with delayed lactogenesis. So early initiation of breastfeeding is the most important step here. Then rooming in. As much as possible, skin to skin contact. Even in cases of terms, it is seen that it not only helps to regularize with infant, altered respiratory rates or heart rates, it stabilize them hemodynamically, but most importantly, it helps with early initiation of breast milk. Avoid unnecessary formula. So just don't think that there is delayed lactogenesis and start with formula, because once you start with formula, then obviously body gets a response that's not needed to be producing more of milk, and eventually breast milk suppression starts. Now, the key takeaway messages here is that most important step is lactogenesis 2, and this cannot be stressed upon enough. Milk removal determines the supply, especially after 7th to 10th day postpartum. Once the milk starts getting produced in good amount, it's always a demand and supply. The more the child is going to suck, the more milk production would be there, and the more would be milk secretion. And early intervention is the key. That's why mothers have to be talked about golden hour and what is its role and what is the importance of golden hour during breastfeeding much before the mother is even delivered the baby. So I hope this is useful for you for your exams. Thank you so much.